in an hour, so I'll get cracking shortly. So I hope you can all hear me all right. As always, the session is being recorded, so do be aware of that. And as always, please do turn off your video and mic if you haven't already done so. It just gets a bit distracting. Please don't take control. It causes me so much stress and it makes me want to cry. So please try not to take control of the presentation. If you have any questions, do type them away in the chat area. And this is an awful lot to get through in an hour, so we'll do our best, but there will be time at the end for any questions as well. So this is a session that's mandatory for all of you, whether you're in Group 1 or Group 2. And it really builds on all the things that we've done so far about virology, immunology, PPE and decontamination. We did touch on COVID-19 in the intro session, the very first one I did, but this is obviously a lot more in depth. Although obviously it's only an hour and we could talk far more about all of the topics. So it's always worrying when I can't move to the next slide. Okay, so the aims and objectives of the session are that you will have an understanding of the epidemiology of COVID-19, that you will understand how it's transmitted, you'll understand about how the disease presents, the disease course, a bit about treatments and any potential future treatments or vaccines. We're going to touch on that at the end, and a bit about how COVID incidents and outbreaks are managed. And we've got quite a few of those going on at the moment, I have to say. And then, sorry, my laptop seems a little bit unresponsive. So the topics we're covering are what is COVID, how it's transmitted, the epidemiology, the setup here at Sandwell, how it all works, how to manage outbreaks, a bit about the PPE, a bit about treatments and a bit about the vaccination. So that's what we're going to be looking at over the next hour. So COVID-19 is a viral infection, and it is it's a disease caused by the SARS-CoV-2 virus, and it's a type of coronavirus. So in the very first, in one of the virology sessions, we talked about viruses, and this is the classification of the different virus families. And coronaviruses are here. They are an RNA virus, and they are an enveloped virus. So that's where they sit in the family tree, if you like, of viruses. But don't worry too much about that. This is a diagram of what SARS-CoV, of what a coronavirus looks like. And you've got an envelope around the outside, keeping it all in together. And then you've got the genetic material in the middle of the virion here. And you've got these spiky bits of protein that stick out. And the reason they're called coronaviruses is because it kind of looks a bit like a crown. That's where it got its name from. And coronaviruses can cause different diseases. They can cause respiratory infections. They can cause gastrointestinal infections, so sickness and diarrhea. And the respiratory ones tend to cause either the common cold or pneumonia, which are usually mild. So we have all had coronaviruses dozens and dozens of times throughout our life because we've all had the common cold. And the common cold is caused by lots of different viruses, but including coronaviruses. The problem is there are 3 types of coronavirus that can cause very severe disease. So SARS, which was identified in China in 2003, MERS-CoV, which is Middle Eastern Respiratory Syncytial Virus, which was identified in Saudi Arabia in 2012, and then SARS-CoV-2 coronavirus, which obviously was identified in China in 2019. And coronaviruses have caused really 3 outbreaks. So SARS caused an outbreak back in 2002, and some of you might remember that. And in total, there were just over 8,000 cases in 17 countries, and 744 people died. So, and SARS then pretty much went away, thank goodness. But then in 2012, we had Middle East Respiratory Syndrome, so MERS-CoV, and There's been a total of 2,500 cases in over 21 countries, and about 860 people have died from that. And of course, COVID-19, we first knew about it in 2019, and we're getting new cases on a daily basis. And unlike SARS and MERS, COVID-19 is a pandemic. And a pandemic just means it affects the entire globe. It's every country on the planet is affected with this at the moment. So it's not just 17 or 21 countries, it's every single country. So a little bit more about the virus. We've covered this before in virology, but it's an RNA virus, and the virus is called SARS-CoV-2, and the virus causes the disease COVID-19. And this is what it looks like. Again, so we've got these spiky bits of protein that stick out. We've got this fatty envelope here that keeps it all in. And then we've got the RNA in the middle, which is the genetic information of the virus. And this fatty envelope here, as we know, it's really easy to disrupt with soap, with alcohol. So washing our hands is very, very effective. So we can neutralize the virus very easily with just good old-fashioned soap and water. Could I just ask to please put your microphones on mute, please, if you haven't already done so? That would be really great. So the incubation period of COVID-19 is roughly 1 to 14 days. So if you are exposed to somebody today who has got COVID-19, it will be between 1 and 14 days that you develop symptoms. And it's usually around about 5 days, but it can be as little as 1, it can be as many as 14. And we're pretty infectious whilst we're symptomatic, but we're also infectious before we even develop symptoms. And also some people can be completely asymptomatic. Some people can have the virus and be shedding the virus, but don't have any symptoms at all. And we think that's particularly common. And of course, that's a problem, because if somebody doesn't know they've got symptoms, they might not be taking precautions as they would be if they felt ill. So that's a really good way for the disease to spread. And pretty much most people are going to recover in about 1 to 2 weeks. If you have mild case of COVID-19, about 1 to 2 weeks, you're going to feel better. However, if you've got severe or critical, it's longer, 3 to 6 weeks, and it can be even longer than that if you've been incredibly ill and you've been on intensive care. So mild cases recover far quicker than severe cases. We do need to know a lot more about pre-symptomatic and asymptomatic transmission. Obviously, this is a new disease and it's an emerging disease, and we're learning more about it all the time, but we do need to know more about that. So that's an area of study at the moment. And certainly once you've been infectious for about 7 days, it's thought that you are no longer or less infectious. However, hot off the press today, the government have announced that the isolation period is being increased from 7 to 10 days. So if you've got symptoms of COVID-19, you now have to isolate at home for 10 days, not for 7. And that's obviously to kind of err on the side of caution, really. So most people are probably not infectious at 7 days, but some will be. So if we're keeping isolation going for longer, we're going to have fewer people walking around who are shedding the virus and infecting other people. So yeah, hot off the press this morning, we are the isolation period is increasing. So symptoms of COVID-19. So this is an observational study of 1,420 patients, all of whom had mild or moderate disease. So they weren't severely or critically ill. And they looked to see what the most common symptoms were. The most common was headache and also a loss of smell. So over 70% of the people reported those symptoms. Nasal congestion, cough, weakness, muscle pain, and runny nose were all very common as well. around about 60 to 63%. And a loss of taste and sore throat was also a relatively common symptom as well. So it seems that these symptoms are quite common. People do report them quite frequently. And if any of you has had COVID-19 or think you have, you may well recognise some of these symptoms on the list here. There are some real complications of COVID, and we're learning a lot more about this. You know, the more we know about this disease, and it's important to keep emphasising this is a new disease, and we are learning more every day. It's not something that's well understood, like influenza, for example. And there are some recognised complications now from COVID-19. And the first one there on the list is ARDS, so acute respiratory distress syndrome. So this is an acute syndrome. It's not like somebody who's got chronic asthma or chronic pulmonary disease. It's an acute, sudden onset respiratory distress syndrome that often, or will certainly result in a patient ending up being ventilated on an intensive care unit, as you can see here. So what happens is the person has to be sedated, a tube is put in their throat, that's called intubating them, and they're hooked up to a mechanical ventilator to breathe for them. And really, if you end up this ill on an intensive care unit, your prognosis is pretty poor. So we know it can cause ARDS, which is a real significant problem. It can also cause heart problems, so myocardial injury. It can injure the heart, it can cause heart arrhythmias, it can cause inflammation of the heart and heart failure. So you know, the virus does seem to attack the heart as well as the lungs. We know it can cause acute kidney injury, and often people who are critically ill on an intensive care unit here, they do end up with multi-organ failure. So their lungs might fail, but their heart might fail, their kidneys might fail, their liver might fail. It's more than one organ failing. And the more organs you've got failing at once, the worse your prognosis is. So often acute kidney injury, and that often requires supportive therapy as well. And it also seems to affect how our blood clots. So coagulopathy just means a disorder of the clotting of the blood. And one of the things that we're learning is that, you know, COVID-19 can cause clotting problems, and it can lead to thrombosis, where you get clots forming in the bloodstream in the organs, and that can lead to organ damage and to organ death. So that's another complication that we're beginning to recognise and we're beginning to learn more about. So although most of us, if we get COVID-19, most of us will get a mild disease, those of us unlucky enough to get severe disease, it's a deeply unpleasant and highly dangerous disease. Obviously, we're learning more about this, and I've kept this deliberately vague because depending on which paper you read, you get different data. But about 20% of people are ill enough to require hospital admission. Now, that's probably an overestimation, because many people, if somebody's completely asymptomatic, they're never going to get tested, so they won't know they have COVID-19. So all those people who've got asymptomatic infections, they don't appear in the statistics here because they're so, you know, they don't even have symptoms, let alone require hospital admissions. And many people who have very mild symptoms might not have been tested. So when we say 20% require hospital admission, it's actually probably fewer than that. It's probably fewer than 1 in 5. And the case fatality rate, we're still trying to figure it out, and it depends on the testing. It's quite an approximation because, of course, the people who are well and the people who are asymptomatic or who have very mild disease may not get tested and so don't appear in the figures. But we think that the case fatality rate is basically how many people die of it. So SARS had a case fatality rate of about 9.5%. So if 100 people caught SARS, about 9 or 10 of them would die. So pretty high. You know, 1 in 10 is not great odds. You don't want to have a 1 in 10 chance of dying. MERS is even higher. The case fatality rate for MERS is 34.4%. So really, you know, 3 out of 10 people who got MERS died, which is really poor. And seasonal flu is about 0.1%. And And we think we think COVID-19 is higher than seasonal flu. Certainly more people die of COVID-19 than they do of seasonal flu, but it's certainly not as high as SARS or MERS, the other two coronaviruses that we are worried about. And it's important, I think, as well to remember that COVID-19 is very infectious. So it's highly transmissible. It will spread quickly from person to person. So even a relatively low case fatality rate, if a lot of people are infected, that will still mean a lot of deaths. So even say if our case fatality rate was 1%, so 1 out of 100 people who caught it would die. If 1 million people caught it, that's an awful lot of people who have died. So that's another thing to just remember there. Any questions so far?
There's nothing in the chat, Valerie.
Thanks, Reg.
Actually, I've got a question. It's Sarah here. I couldn't quite type it fast enough. It's all the stuff that's in the media about the PHE data, mortality data, and the way it's collected, suggesting that it's not accurate and that the death rates are actually lower. I don't know much about it. I caught something on the telly yesterday.
That is a really good point, and I'm going to come on to that shortly. So I'll put your question on hold, if that's all right, Sarah, and talk about it in a few slides' time. But yeah, you're spot on. There's some issues there. So the main way that COVID-19 spreads is droplets and contact. So we've talked about this before, but when we talk, sing, cough, sneeze, do whatever, we're releasing respiratory droplets into the air. The droplets are heavy, they fall to the ground, the aerosols tend to float around, but they can be inhaled by another person. The droplets can contaminate the environment. So I'm talking to you now in front of my laptop. My laptop is covered in my respiratory droplets. So if I had a respiratory infection like COVID-19 or flu, the virus would be on my laptop. And it spreads this way. So we think that the main two routes of transmission of COVID are droplets and contacts. So coughing, sneezing, and contact with other people or with the environment. There are some other possible modes of transmission that they're not as significant and they're not as well recognised. Now we know that we can find the SARS-CoV-2 virus in body fluids. So it's been found in the sewage system, and there's some really interesting papers actually looking at the sewage systems of different countries to see when the virus first appears. So that's kind of a new way of doing disease epidemiology that's quite interesting, grubbing around in the sewers. But really any body fluids apart from sweat, we have to assume will contain the virus and so are potentially infectious. So you know, respiratory droplets are obviously a worry because they're released normally. We don't tend to come into contact with the urine and feces of other people, but healthcare workers, etc., certainly do, and we have to assume that all body fluids are infectious. And then I've put a long list there of aerosol generating procedures. So an aerosol generating procedure, it's not usually done. They tend to only really be done in healthcare, so like this intensive care unit, or we do have a couple of care homes in Sandwell where we have people who have got tracheostomies, and certain procedures increase the amount of aerosols that a person produces. And if that person has got COVID-19, they are releasing a lot of aerosols into the atmosphere, therefore there is a lot of potential for viral spread. So this is a very long list of aerosol generating procedures that will be done in hospital or in a very specialist care home setting where there is an increased risk of viral spread. But really, for the most part, for the community, we're talking about contact, either direct or indirect, and we're talking about droplet spread. So that obviously informs the PPE that we use, and I talked about this the other week in the session about PPE, so I'm not going to go into it in any great detail, apart from to say that PPE is not required in the community. We should be wearing a homemade face covering when we're going into the shops and when we're on public transport, and keep the masks for the NHS. But in the NHS or in care homes, if somebody is having an aerosol generating procedure, then the PPE is gown, gloves, mask, eye protection. Whereas if it's just general contact in a hospital or a care home setting or domiciliary care, it's gloves, apron, mask, and maybe eye protection if there's risk of splashing. So that's the PPE that's required, and that's based on what we know about the mode of transmission of the disease. You'll have heard a lot of talk about R. It's talked about an awful lot in the media, and some politicians and some in the media are really, you know, everything's based on R. What's R doing? And R is useful, but it's also got limitations, and I think sometimes we're perhaps putting too much faith into it. So, excuse me. R is basically an estimation about how many people one sick person will infect. So if somebody has COVID-19, they will infect on average about 2 to 3 other people. So one person with COVID-19, they'll spread it on to 2 or 3 other people. Seasonal flu down here, one person with seasonal flu will spread it on to 1.3 people. You obviously can't have 0.3 of a person. So, 100 people, 13, that's the way that works. So flu is far less infectious than COVID-19. Norovirus here, winter vomiting disease, many of us will have had this. That's more infectious than flu, perhaps about the same as COVID-19. So one person with norovirus will give it on average to 1.6 to 3.7 people. Ebola. So Ebola is a dreadful disease. It's a viral hemorrhagic fever. As I'm sure you know, there were outbreaks in 3 Western African countries a few years ago. And Ebola is very feared because it has a very high mortality rate. But it's it's less infectious than COVID-2. It's not spread by, it's not a respiratory infection. It's not spread by droplets. It's really contact. But you can see here measles. So measles is probably the most infectious disease on the planet. One person with measles will pass it on to 11 to 18 people, assuming that nobody's got any immunity. So you can see that measles is a highly, highly infectious disease, far more so than flu, noro, COVID-19. But COVID-19, one person can give it to about 2 to 3 other people. So that's not great. Because it means that more and more people get infected, because those 3 people can then give it on to another 3 people each. So you can see how quickly that can spread. It's important to remember that this is retrospective. We don't know what the R number today is, either in Sandwell or in the UK. We know what it has been in the past because we can see what's happened and how the disease has spread, but we don't know what it is today and we don't know what it is tomorrow. So it's a retrospective figure. It's always kind of looking back. It's also incredibly imprecise. This is an estimation, and there's an awful lot we don't know. Not everybody gets tested. So, the more we test, the more accurate R is. The less we test, the less accurate it is. And it will change. The R number today is different from the R number back in March. It will change over time. And also it's not uniform. So the number of people being infected in Sandwell is different from the number of people being infected in London, and that will be different again from the number of people being infected in Glasgow. This is not a uniform number. We can't say, well, we do, but we say, the R number in the UK is whatever, but actually that's going to have a lot of regional variation underneath it. So R is useful, but it's also quite crude, and we need to just be aware of its limitations. This is a slide from Neil's lecture the other week, and it's just to highlight that some people are more at risk of COVID-19 than others. So some people were told to shield. They were considered to be especially at risk, and so that they were shielding at home. And we know that if you're over 60, your risk is higher. If you're pregnant over 28 weeks, if you've got several underlying medical conditions, if you're from a Black or minority ethnic group, all of these things can increase your risk of ill effects from COVID-19. So not everybody has the same degree of risk. And we're still learning an awful lot about the underlying medical conditions that impact on the severity of COVID-19. So I'm going to talk about the epidemiology now, and Sarah, I'll be answering your question earlier in this section, so I'll get to that in a little while. So what happened with COVID-19? So this is a timeline. So I showed you this in the first lecture that I did, which was the intro. And really, it seems like so long ago, but it was the 31st of December last year that China first reported a cluster of cases in Wuhan. And by the 12th of January, we'd identified a novel coronavirus, which we later knew caused COVID-19. By the 25th of January, we knew that we had person-to-person transmission outside of China. We got our first 2 cases in the UK on the 31st of January. WHO declared a pandemic on the 11th of March, and that just means it's affecting the entire planet. Every region of the world is affected. And then on the 23rd of March, the UK government implemented lockdown. So an awful lot has happened in a very short period of time with COVID-19. So we've got a few slides now basically just showing how the distribution of cases and deaths has happened. So this graph here goes back to the 31st of December last year, up until it finishes on, I think, the 28th of July. So a couple of days out of date, but not too bad. And this is the number of cases. And we can see at the beginning, we had the cases were grey. So this is pretty much Asia. So really back in February, the cases were mainly in China and in Southeast Asia. And then we can see that as the weeks went by, we started to see more cases in Europe, and Europe was a big problem there. Asia still continued to be cases there. But you can see what's happened here. So this is America. So this is making up a massive amount of the total number of cases. Africa down here, there are fewer cases there. That may well be down to reporting, because of course this is confirmed cases. So countries that have really good testing will have a higher proportion of confirmed cases where there is less testing. So we've always got to be a little bit cautious of these kind of graphs, because it's always going to be dependent on how well countries test or how poorly they test. And of course, at one point in the UK, we weren't testing. So basically, we didn't know what was going on in that period. So this is deaths worldwide. And again, you can see at the beginning, very few deaths. And it was really in Asia where we had the first few cases. And then you can see that over time, Europe, massive problem here in Europe around about April. The main deaths there were happening in Europe, but really America has taken over, and we've got a lot of deaths in America at the moment. And really, the latest data I was looking at this morning when I was just updating this, that since the 31st of December, 17 million, over 17 million cases of COVID-19 globally, and there are 666,857 deaths. Now that's going to be an underrepresentation probably, because it depends on testing and it depends on death reporting. But there have been at least 666,857 deaths globally. This is obviously it's a map of the globe, but it's just showing where the cases have been in the last 14 days. So the previous 2 graphs are since the beginning. So this is just the last 2 weeks. And the countries that are in red here are the countries that have got the highest rates of COVID-19. And these are rates per 100,000. So it doesn't matter if it's a country with a very large population or a very small, it's a rate, so it's standardized. And we can see here that, you know, America, the United States of America, have got very high rates, as have many South American countries, as has South Africa here. England, the UK up here, you know, we're at a lower rate than many parts of, you know, Russia there. Some parts of Europe have higher rates. And then some countries have no new cases reported, and I would suspect that's more to do with reporting issues than that there are no cases. Certainly there, North Korea. I'm fairly certain there are cases of COVID-19 in North Korea, but King Jong-un is just keeping it rather quiet. So you can see really that, you know, what's going on in some of these countries is, you know, we're getting high levels of cases. And then this is the England epidemic curve. So this is all cases. So this is all confirmed cases in England. And the graph here starts back in January, February. And my pointer's not showing up for some reason, probably the background. And you can see that we had the most cases back in April. So the end of April, the beginning of May was the peak of our epidemic curve, and it's tailing off now, hopefully quite nicely. And long may that continue, although we could well see a second wave. Oh, and this graph here, so this again is England data only, and it's just showing the split of confirmed cases by age and by gender. So we can see at the, you know, this is the female side, and you can see that we've got more cases in that 80 plus group, fewer in the under fives, and it's the same for males over on this side as well. So few cases in the very young, but quite a lot in the older. And male, female, it seems to be about the same. We've got more cases in females over 80 than we do in males, but that's because women, I imagine that's because women live longer than men do. So there are more women over the age of 80. Now this is deaths. So this is England deaths until the 21st of July. And we can see quite a different picture there. So you can see that the vast majority of deaths are in people over the age of 80. And that's true of men and women. There are very few deaths in the under fives. And really, it's up until you get to about the 50 age group, or, you know, that you start to see more deaths. So this is a disease that kills people who are older. There are some very tragic deaths in the very young, but really it's the over 50s, the over 60s, certainly the over 80s who are most at risk of death here. And Sarah, you made the point earlier that the way we count deaths, so this is showing the number of deaths in people who have had a lab confirmation of COVID-19. So somebody could have tested positive for COVID-19 back in March, and they got run over by a bus last week, and they will appear in this data set. So it's a really crude way of counting deaths. You know, this is anyone who had a positive test for COVID-19 who has since died. So they may have made a full recovery, and then they got hit by a bus and they died because they were in an RTA, but they will appear in this data set. So yeah, there are going to be some people in this data here who didn't die of COVID-19, they died of other reasons. And of course, people over the age of 80 are, you know, at risk of death, that they're old. So you would expect to see deaths in that age group there as well. But then it's also probably important to remember that there will be people who are dying of COVID-19 who never were tested in the first place. So it balances out so that the data, they are quite crude. Data is always crude, and our data here is rather crude. And then as of Tuesday, we have had 300,692 lab confirmed cases. And as of Tuesday, we've had in the UK 45,878 people who have died. And you can see there from the definition that the deaths are people who have had a positive test result. It's not necessarily people who died of COVID-19. It could be my hypothetical person who was tested back in March and then got hit by a bus yesterday. So just to be aware of that. So another way of looking at it to try and get round this is looking at everybody who's died. So here we're looking at people who we think have died of COVID-19, but we know that there's some issues with the data. So why don't we look at everybody who's died in England and Wales and then see what's happened there? And this is what this graph is showing here. So this blue line here is deaths. So it's number of deaths registered by week in England and Wales. And there's always a few spikes after bank holidays. A death doesn't get registered on a bank holiday Monday, so the following day you see an increase. And this dotted line here is the average death notifications over the last 5 years. So this line here is our average. It's what we normally report. And you can see that we have slightly more deaths in the winter months than we do in the summer months, because people tend to die more often in winter than they do in summer. We know that. So this is the average number of deaths. And you can see here that this year's number of deaths were about average until all of a sudden at the end of March, the death rate was well above the average. It was far more deaths were being reported in March, April and May than is usual for that time of year. That's the normal, that's what we were reporting. Influenza and pneumonia was about the same. So the blue line there is deaths involving influenza and pneumonia. So it wasn't flu, we didn't have a particularly bad flu season. But here you go, the deaths involving COVID-19. So even if we've got all the problems with how do we classify if somebody died of COVID-19 or not, this is everybody who's died in England and Wales. And March, April, May, far more people were dying than normally die of that time of year. So something very different happened because of COVID. So we know a lot of people have died of COVID, even though we know there's always accuracy issues with data. So looking at the Sandwell picture, as I'm sure you all know, we have a Sandwell spike. So this is just a line graph showing daily COVID cases per 100,000 of population. And Sandwell, we are the line in green here. So it's going back to March, the middle of March, and we had lots of cases in March, we had lots of cases in April, and then really by early May, the number of cases across the Black Country and across England started to decline. So it started to go down, which was great. The blue line here is England, so you can see that there, but the green line here, you can see we are going up in Sandwell. So this is our Sandwell spike. We're significantly above anywhere else in the Black Country, and we're above England. So we do have an increased number of cases at the moment in Sandwell, and we're working incredibly hard at the moment to try and counter that and to try and get that under control. So the control measures, we've talked about these before. The most important ones are things like social distancing, keeping 2 meters apart, respiratory hygiene, washing our hands, cleaning our hands, staying home if we're unwell. So we're now isolating for 10 days, not for 7 if we've got symptoms. And if we are a contact of a case, we have to isolate at home for 14 days. So contact tracing is absolutely crucial in controlling COVID-19. And a lot of the outbreaks we've got going on at the moment, we know what's behind it is people who are symptomatic, or even people who are confirmed cases have gone into work for whatever reason. So these control measures are effective, and they are even more important now than ever because of our spike in cases. So I'm going to talk about testing now, just briefly. We touched on this before in the virology session, but testing for COVID-19 is obviously very important. And there's two types of test. There's the test which tells us if we've got infection. So this is it's a PCR test, a polymerase chain reaction test. I can't remember. I'm sorry, I'm having a blind moment there. But basically, it's a swab from the nose or the throat, and we're looking for viral RNA. So if you've had one of these, you'll know it's pretty unpleasant. It makes you gag. It's a swab to the back of the throat. It gets put into this machine here, and it will spit out a result. And it's just looking for virus particles, basically. And it will tell you, do you have infection at the moment, yes or no? And this is what we get tested if we get symptoms and we think we've got disease. There's also, so that's the PCR testing. It tells us if we've currently got the disease, but there's also antibody testing. And this is a blood test, so it's not a throat swab. And this tests to see if somebody has been exposed to the disease in the past. And there's actually quite a lot of research looking into this at the moment, because we need to know how many people, well, certainly globally, but also in the UK, in England and in Sandwell, how many people have been exposed to the disease. And it's important to remember that just because you've got a positive antibody test, it doesn't necessarily mean that you're immune. It might do, it might not. And if you are immune, we don't know how long that immunity lasts. And that there's some evidence that's coming out that suggests that immunity may not last that long. So we can't be complacent. Now, there's a biobank study at the moment, which is testing antibodies. So over 20,000 people across the UK have been included in the biobank study, including me, actually. I've been jabbing my fingers and sending off my blood. And basically what biobank are doing is they're collecting blood samples from people who they've stratified to be representative of the wider population, and they're asking them to send off blood samples once every month. And we've got the month one data back, and this is what this is, it's month one data. So bear in mind, it's only 1 month's worth of data and it's an ongoing study, but it's interesting nonetheless. So this graph here shows women and men and how many people were positive, what percentage of people were positive. And you can see it's only about 7%, both of men and women, who tested, who had positive for antibodies. So if this is representative of the wider population, only about 7% of the UK have been exposed to COVID-19 so far. So that's not great for herd immunity. This graph here shows the percentage of people who have got antibodies by age. And we can see, unsurprisingly, that people who are under 30, about 10% of people under 30 have antibodies to COVID-19, whereas only about 5% of people who are over 70 have antibodies. So the younger you are, the more likely you are to have antibodies and so have been exposed to COVID-19. And that's not surprising because, of course, older people have been shielding and have been staying at home. Whereas younger people under 30 have perhaps been less likely to follow social distancing. So they've been looking at ethnicity as well, and obviously we know about BAME groups being at more risk, and really this is less conclusive. So it's around 11.3% of people who are black have got antibodies, 9% South Asian, 9% other, 8.7% mixed, 7% Chinese, 6.9% white. But really the confidence intervals are quite wide. So there's probably not much difference there. So it doesn't look like there's much difference in between the different ethnic groups who've been exposed to COVID-19. And this is showing the regions. So about 10% of people who live in London have got COVID-19 antibodies, and West Midlands, we're in second place. About 8.4% of people in the West Midlands have been exposed to COVID-19, and then going all the way down to Scotland, 4.4%. But those of you who know about confidence intervals will see that the confidence intervals there are quite wide, and this is only 1 month's data, so we need to know an awful lot more. But unsurprisingly, London, the West Midlands, areas with lots of urban populations, you're more likely to have been exposed to COVID. So 7.5% of people living in a rural area have COVID antibodies, whereas only 4.8% of people living in a rural area have COVID antibodies, and that makes sense. And then I think this is really important. The more deprived the area you live in, the more likely you are to have been exposed to COVID-19. So 8.9% of people in the more deprived areas have got COVID antibodies, whereas in the less deprived areas, that's 6.1%. And we know this, we know that, people were talking at the beginning about this being the great equalizer, and we know that's not true. If you live in a deprived area, you are more likely to have been exposed to COVID-19, and we can see that quite clearly here. So for the last 15 minutes, and it is an awful lot to get through, so I'm sorry if I'm rushing, but we're going to talk about vaccine development and treatments. Does anyone have any questions so far? I'll take that as a no, that's great. If you do, please type away in the chat box and Raj will shout out. So vaccine development, obviously there is a massive, huge global effort to try and develop vaccines. And really this would be the game changer. We need a vaccine. And there are at least 10 vaccine candidates that have entered clinical trials, including phase 2 trials. And there's one that's looking quite promising in Oxford, but there are others. And, it's not certain that we'll get a vaccine, although it is looking a bit promising. So let's hope that we do. If one is developed, that it will be very challenging. How do we manufacture enough that we have enough to reach everybody on the planet? How do we get the people most at risk? How do we reach them? How do we mobilize it? Where do they go to get their vaccine? It may well be that you need more than one vaccine. So it's not a case of you go along once and get a jab in your arm and that's it. You may have to go back for 2 or 3 or 4. It may have to be given every year, the way we get the flu vaccine. So there are lots of challenges towards vaccine development, although there are some promising noises in the background. So watch this space. So that brings us on to treatment. So vaccine either prevents us getting the disease, or it means if we get the disease, we get it in a much milder form. But we need to look at treatments as well. And there's been quite a few splashed over the media, so I'm going to talk about them quite briefly, not in any detail. And I'm not going to talk about pharmacology because I wouldn't know where to begin. But I'm just going to talk about some of the ones that you might have heard of and how effective or not they may be. So the first one is dexamethasone. So dexamethasone is a steroid, and it's used in quite a lot of different conditions because it's got anti-inflammatory properties, but it also suppresses the immune system. And there was a randomized controlled trial in hospital patients, and it was done here in the UK. And this randomized controlled trial found that it did have benefits for critically ill people. And it found that if you're on a ventilator, so if you're so sick that you've been admitted to ITU and ventilated, dexamethasone reduces your mortality by about 1/3. So 1/3 more people survive on dexamethasone than they would have done otherwise. And if you're ill, requiring oxygen, but you're not ill enough to be ventilated, your mortality, so your likelihood of death has been reduced by about 1/5. So that's pretty great. But its effect is for people who are ill enough to be hospitalized. It doesn't prevent the disease, and it doesn't kill the virus. That's important to note. It's a supportive treatment. It just reduces inflammation throughout the body. But dexamethasone has got some proven efficacy and is being used. There's been some studies on the antiretrovirals that are used against HIV, and some studies have suggested that there are good clinical outcomes, and almost all the cases who are given antiretrovirals fully recover. But, and there is a massive but there, the studies that show this were all very small studies, and all of the patients who got the antiretrovirals also got other treatments as well. So we really don't know what worked. Was it the antiretroviral or was it the other thing that they were given? And so the quality of data there is really quite poor, and we need an awful lot more data to say that antiretrovirals work or don't work. So dexamethasone, yes. Antiretrovirals, maybe, but more evidence is required. So plasma is another one. So plasma is a blood product. When you donate blood, you can get the pooled plasma taken out of the blood, which contains the white blood cells and antibodies, and then that plasma can be given to another person, and there is some evidence that convalescent plasma does have some effect. And there were 2 studies in China where they said people who got the plasma, so plasma donated from people who'd recovered from COVID-19, these studies showed that the people who got the plasma did better than those who didn't. But there are some massive limitations. So those studies were not randomized. And if you don't randomize your studies, the risk are you're cherry picking who goes into your study, and the people you think will do better end up getting the treatment. So unless the study's been randomized, it's of limited value, but there's more research ongoing at the moment looking at this. And so that may have some effect as a treatment. And then hydroxychloroquine. So this was Donald Trump. So Donald Trump, in one of his infamous press conferences, said that he's taking hydroxychloroquine, and you know, he's convinced it works, and it's the cure for COVID-19. And actually, there was a trial called, well, there is a trial called the Solidarity Trial, and it's looking at lots of different treatments. It's an international trial, and it's trialing lots of different drugs to see what, if any, of them are effective. And hydroxychloroquine was one of the trial arms in this trial, but it was stopped because it was really clear that it did not result in any decrease in deaths in people. So it wasn't ethical to give them a drug that has side effects that we know doesn't work. So this drug is used for malaria, and it is used for some autoimmune diseases, but it does not have a role to play for COVID-19. Because of the Donald Trump effect, the WHO had to come out with one of their mythbusters to say that while it is safe for people who have malaria and autoimmune disease, it is not effective against treating COVID-19, and people should not be taking it. So yeah, Donald Trump was wrong. Shock horror. And then finally, for treatments, antibiotics. So of course, COVID-19 is caused by a virus, and antibiotics don't work against viruses, so they should not be and are not used as a treatment. However, people with COVID-19 can get secondary bacterial infections. So they can go on to get a pneumonia, for example, if they're severely ill. And so that secondary bacterial infection would need to be treated with antibiotics. But antibiotics treating COVID-19 will do absolutely nothing. So COVID outbreaks. So we have a few of these. You'll have seen in the media that there are a few of these locally in Sandwell, and how we manage them can be quite interesting. So an outbreak is if 2 or more people have the same disease or the same symptoms, and they've got to be linked in time, place or person. So you might have got a group of people who work in a packaging factory, for example, and that would be considered an outbreak. The other definition of an outbreak is a greater than expected rate of infection, and we're certainly seeing that at the moment with COVID-19. So outbreaks, 2 or more cases related in time, place and person. And how to control an outbreak. There's 4 steps to controlling an outbreak. And the first one is we've got to know about it. And at the moment, we've got people in the public health department who've been ringing round businesses and workplaces across Sandwell saying, you know, here are your control measures, but if you get 2 or more cases in your workplace, please do let us know, because if we don't know about it early, there's very little we can do about it. So early detection is absolutely crucial. The sooner we know about an outbreak, the more we can intervene. And then we need to investigate the outbreak. So we might just have descriptive epidemiology. So we might have epidemic curves. We might say 3 people who worked in room A together all became infectious, all became symptomatic on the Monday, 4th person on the Tuesday. So we'll describe the outbreak and we'll investigate it. We'll obviously introduce the control measures. And one of the lessons that we're learning from our outbreaks is that while everybody knows what the control measures for COVID-19 are, they're not always being followed. And I think people are going back to normal slightly, and it's not like it was back when lockdown first started. And so social distancing is perhaps not being maintained as strictly as it was before. So we have to introduce those control measures. And then at the end, we evaluate and do the lessons learned. And that's the step that's often missed, but it's very important. So that's the steps to controlling an outbreak. And you need to have regular meetings, regular IMTs to discuss the issues and to make sure that everybody is involved who needs to be. We have our outbreak plan, and this is well worth a look at. It's our award-winning outbreak plan. So this is on the website. You can see the link there. So I do recommend that you have a look at that. And then here in Sandwell, we've got kind of 3 key roles really in dealing with COVID-19 within health protection. So we've got consultant leads, so myself, Annie, Paul, Tanith, obviously Lisa McNally as DPH. I can't believe I missed the DPH off. I hope she's not on this call because she's obviously the most important one of us all. But we've got the consultant leads who will take the lead on any outbreaks, whether it be in a school, a workplace or a care home, and also a second on to provide cover on a day-to-day basis. We have a 7-day-a-week service. We're covering weekends as well. We've got health protection practitioners. So those of you on this group who are in group 2, that's you guys, and you have started this week and last week to do the first on role, dealing with inquiries as they come in and giving health protection advice. And you've all been doing an amazing job. And then you've got the information officers. So for those of you on this call who are in group 1, that's you guys, and that's collecting data, gathering information, and it could be in any setting, whether it's care homes, contact tracing, schools, workplaces. And really all 3 roles are equally important in managing this pandemic and managing our Sandwell spike at the moment. So we're aware of time, so I'm just the last few slides that's COVID-19. And we've talked about the mortality and the disease progression and the deaths. But what about the wider implications? Are there any silver linings? Are there any other dangers? And yes, there are. There are some silver linings. I mean, this is a terrible disease, but since lockdown, we have seen a significant reduction in air pollution. So there will be people alive today who would have died from asthma caused by air pollution, but they haven't, because we've seen a reduction in air pollution. We've seen a reduction in traffic as well on our roads, and those are only good things. They will benefit the public health. They may well not last, and we're already seeing an increase again, sadly, but we've shown that we can reduce air pollution, we can reduce our carbon footprint during lockdown, so hopefully we can learn from that. We've also seen some absolutely amazing community groups, you know, people helping out their neighbours, people helping out their communities, people looking out for each other. And I think that's something that's very strong in Sandwell anyway. I came here from London and I never talked to my neighbours, but I'm now in a WhatsApp group with my neighbours in the block of flats. So again, you know, there are some silver linings to all of this going on. But of course, there are the other consequences as well. So domestic violence, we have seen an increase in domestic violence. So people who are trapped at home with their abuser. Could whoever's got their mic on, please turn it off. Thank you. So people trapped at home with a domestic abuser, people, you know, there are people who have been murdered, there are people who have been victims of severe assaults because of lockdown, and it must be unimaginable to be in that situation. We've seen an increase in loneliness. People living alone, they're missing their normal contacts, they're not seeing the people on a day-to-day basis that they would normally see. We talked the other session about PPE, about masks, and about how there's been an increase in waste because of the pandemic, and that will have an impact. And then, of course, there's the impact about the recession. You know, we're on the brink of a recession, and that's not just health versus economy. It's not that simple. We know that people's health depends on how you know, on having a good job, having enough money, being able to, you know, live in a good home. All of those things impact on our health. And if we're coming into a recession, that will have a big negative impact on our health. So there are some other impacts as well. And then I guess just for the final few slides, what does the future bring? And the answer is we don't really know. The virus so far, SARS-CoV-2, has not mutated. It has a little bit, but it's not like influenza. It's not a very unstable virus. But we may see viral mutations in the future. We don't know what the seasonal impact is. Is it going to get worse as it gets colder? And there's evidence to suggest that it might. Is there a vaccination in the horizon? And if so, how soon is it? Will we see a second wave, or even a third and a fourth and a fifth wave? Is this the new normal? Is this here to stay, and it's something we're going to get used to, like flu? And also, how are we going to cooperate globally? This is a disease that affects everybody on the planet. We can't tackle it on our own. We need to cooperate with our fellow nations to come up with a vaccine to beat this. We can't lock down on our borders and try and do this on our own. So really, just to conclude, pandemics aren't new, but COVID-19 is new, and it's an emerging disease. We're still learning an awful lot about it. We've got a spike at the moment in Sandwell, which we need to absolutely stay on top of, and everybody's working incredibly hard about that. And the future is uncertain, and COVID-19 has not gone away. So lockdown might be easing, but this disease has not gone anywhere. And we need to continue to be vigilant and to maintain control measures. There's some more info there, and thank you very much. Does anyone have any questions?
Hi Valerie, Sarah Farmer's just put a question in. Should we expect that things like flu and norovirus won't be as widespread with the measures?
Yeah, that's a really good question. Possibly. I guess there's two ways it could go. Either diseases like flu and norovirus, we will see less of an impact because we're all better at social distancing and we're not shaking hands and things. So we might see a benefit there. But equally, other diseases like tuberculosis, we've all been locked up at home together in close proximity. So we are seeing, and we expect to see, an increase in cases of TB as a direct result of lockdown. So yeah, some diseases we might see a benefit because of COVID. Other diseases we might see you know, further cases. Legionnaire's disease as well, you know, lots of buildings have been locked down throughout the summer, and the water has been stagnant. And if they've not been doing their control measures and keeping the water flushed, we could see more cases of Legionnaire's disease.
Okay, and there's just, sorry, one more in the chat from Sandra Squires. Do dentists use AG procedures?
Sorry, say that again.
It says, sorry, do dentists use AG procedures?
Oh yeah, dentists, yes. So dentists, yes, some of what dentists do are aerosol generating procedures. Certainly anything that involves, I think, drilling is an AGP, and there are other things. So it depends what you're going along for, but some dental procedures are aerosol generating procedures, and the dentists do need to wear filtering masks, yes.
Okay, there's nothing else in the chat. Thank you.
Thanks, Raj. Does anyone want to shout out with anything or type anything else? Lovely. So we'll stop the recording and thank you all very much for joining.